Welcome, you insightful medical professionals, to the deep dive. Today, we're embarking on, well, quite an extraordinary journey. We're looking into the unwavering commitment of a physician who really did reshape global healthcare paradigms. We're delving into the impactful work of Dr. Paul Farmer, documented so powerfully in Tracy Kidder's acclaimed book, Mountains Beyond Mountains. This isn't just about one doctor, is it? It's really a deep dive into, a radical philosophy of care, one that fundamentally challenged how we approach medicine, particularly in resource-constrained settings. And I think it still offers crucial lessons for all of us today. It's a real privilege to have you with us today to unpack the layers of Dr. Farmer's, monumental legacy. For our audience, mid to senior medical professionals like yourselves, what's the core mission here? What do we hope you'll take away from exploring Dr. Farmer's life through Kidder's narrative?
Thank you. It's a pleasure to be here. Our mission today, I think, is to really distill the crucial insights from Dr. Farmer's life. Insights that remain profoundly relevant for anyone in medicine, actually, regardless of your specialty or where you practice. At its heart, it's about understanding his deep-seated conviction. His belief that world-class healthcare isn't some sort of luxury, or a privilege to be rationed based on economics, but rather it's an undeniable, fundamental human right.
Right.
We'll delve into how he systematically dismantled these long-held preconceptions about poverty and healthcare, and not just through argument, but through sheer tireless dedication, relentless action, and a clear-eyed understanding of these complex, interconnected social, political, and economic systems.
That interconnectedness seems key.
Absolutely. Ultimately, we aim to extract practical, actionable lessons. Lessons on advocacy, innovation, and the relentless pursuit of equitable care. Things that resonate far beyond a single specialty, touching every facet of medical practice and policy. His approach, as Kidder portrays it so vividly, offers a powerful blueprint for how we, as medical professionals, can make a significant difference, a lasting difference in the pursuit of justice within healthcare systems. Globally, yes, but also, right on our own doorsteps.
That's a powerful mission and a vital one, particularly for those of us navigating the complexities and, let's be honest, often the frustrations of modern healthcare systems. It really resonates. Okay, let's get into this remarkable story. Tracy Kidder describes Dr. Paul Farmer as a charismatic but flawed genius. What were those foundational beliefs that set him on this, almost messianic quest to heal the world, particularly around infectious diseases and this radical idea of bringing sophisticated modern medicine to those who needed it most, regardless of their situation?
Well, from the very outset, Dr. Farmer's approach was driven by this exceptionally powerful moral imperative, an almost unshakable conviction, really, that guided his every decision, every action. Even as a medical student, as Kidder recounts, Farmer identified what would become his life's calling, not just to understand and cure infectious diseases, which were, and still are, disproportionately hitting the world's poorest populations, but perhaps more critically, to ensure that the life-saving tools, the advanced treatments of modern medicine, the things often taken for granted in wealthier countries, actually reach those who desperately needed them. No matter where they lived or how little money they had, he wasn't content with just, alleviating symptoms or offering basic charity. He was committed to eradicating the very diseases that kept people trapped in these cycles of poverty and suffering.
So a much more fundamental approach.
Exactly. He fundamentally and quite radically for the time challenged the pervasive notion that poverty should dictate the quality or availability of medical care. This wasn't just philanthropy, as some might see it. For him, it was a profound belief in universal healthcare as an absolute human right. He was an unwavering advocate for a system where, and these are his words, every person on the planet deserved the same medical care.
That's quite a statement.
It is. And remarkably, he maintained this view even when faced with arguments about practicality or cost or, logistical impossibility. For Farmer, the moral argument always trumped the pragmatic one. And crucially, he consistently found innovative ways to make the seemingly impractical practical, proving that compassion and competence could indeed move mountains.
That's a truly bold assertion, especially when you think about the constant debates around global health resource allocation. It really cuts against the grain of so much conventional thinking, doesn't it, that focus on efficiency over individual need. Can you elaborate on how his dual background, getting both an MD and a PhD in anthropology, how did that shape this unique perspective? And perhaps more importantly, his ability to tackle these deep-seated systemic issues so effectively?
Absolutely. His concurrent pursuit of medicine and anthropology gave him this unparalleled lens, a truly transformative way to view health and illness. His medical training at Harvard equipped him with world-class expertise, particularly in infectious diseases.
Mhm.
He understood the pathophysiology, the pharmacology, the diagnostics. He was a top-tier clinician.
Right.
But crucially, his anthropological studies gave him a deep, nuanced, and I think empathetic understanding of social systems, cultural beliefs, the impact of wealth disparities, and the complex political landscapes that inevitably interact with and often dictate medical outcomes.
So it wasn't just about the disease in isolation.
Not at all. This dual perspective allowed him to see far beyond the purely clinical diagnosis, to delve into the underlying social determinants of health. He understood implicitly that a patient's suffering or recovery wasn't just a biological event, but a profoundly social one. For instance, he understood that treating TB wasn't just about prescribing a drug, it was about ensuring the patient had food, stable housing, maybe someone to remind them to take their medication factors deeply embedded in their social context.
Which are often overlooked.
Precisely. He recognized that successful medical interventions required not just pills and procedures, but also intricate, respectful, genuine engagement with the communities themselves. Working with people, listening to their experiences, accepting their cultural beliefs, rather than imposing external solutions that often failed because they disregarded local realities. This integrated, holistic approach, marrying rigorous science with profound social understanding, was undeniably key to his effectiveness and the enduring impact of his work. He saw the individual patient within their community, within their social fabric. And he understood that true healing required addressing that entire fabric. For clinicians today, it's a powerful reminder, isn't it? Our patient's journey doesn't begin or end in the clinic room. It's shaped by forces far beyond our immediate reach, forces we must still try to understand and influence.
Here's where it gets really interesting and perhaps most challenging to conventional thinking. One of the most striking aspects of Dr. Farmer's work was his willingness, his eagerness even, to directly challenge these widely held preconceptions about poverty and healthcare, often confronting what seemed like established medical consensus head-on. Can you give us a concrete example? How did he confront this conventional wisdom that so often limited access to essential treatments in low-resource settings?
Yes, a seminal example, and truly illustrative, is his groundbreaking work against multi-drug-resistant tuberculosis, MDR-TB. At the time, we're talking the 1990s, global health policy was very much shaped by what was considered cost-effective for large populations. There was this prevalent, deeply ingrained belief in the global health community that treating MDR-TB in poor nations was just, well, too expensive, too complex, ultimately impractical on a large scale.
So the standard approach was?
The standard approach, often pushed by prominent institutions, focused resources on drug programs for non-resistant TB, cases that could be cured with simpler, cheaper regimens, which meant, implicitly and tragically, leaving those with MDR-TB to die. Often with this cold rationale of doing the greatest good for the greatest number with limited resources. It was sort of utilitarian calculation that Dr. Farmer found utterly abhorrent. He saw it as a profound moral failure disguised as pragmatism.
A failure he just wouldn't accept.
He utterly rejected it. His philosophy was clear, uncompromising. Ignoring MDR-TB cases wasn't just morally reprehensible, a betrayal of human dignity, but also, crucially, a significant public health failure with global consequences. He argued passionately that abandoning these highly contagious resistant cases would actively facilitate the spread of the most dangerous kind of TB globally, a threat far beyond the immediate community.
Right, it wasn't just contained.
Exactly. He challenged the very premise that cost should be the primary determinant of care, especially when human lives and broader public health were so clearly at stake. For him, the moral imperative to treat far outweighed any perceived economic burden. It wasn't a choice of charity. It was a public health necessity.
So if the prevailing medical consensus, based on what many saw as practical economic realities, was so strongly against him, how on earth did he manage to prove his point? What actual evidence did he bring that ultimately shifted global policy on such a critical issue?
Well, he didn't just argue or preach. He demonstrated meticulously, relentlessly. He established a test site in the slums of Caraballo in Lima, Peru, a real-world setting marked by profound poverty, limited resources, significant logistical challenges. And he set out to prove, unequivocally, that MDR-TB could be successfully treated even there. Now, this wasn't simple. MDR-TB wasn't just resistant. It often required a cocktail of multiple second-line drugs. Injectables like kanamycin or amikacin needing daily injections, sometimes for months. Oral agents like cycloserine, ethionamide, PAS drugs known for severe side effects.
Side effects like?
Oh, hearing loss, kidney damage, serious neurological issues, depression, anxiety, even psychosis. Treating this required meticulous, careful diagnosis to figure out which combination of drugs were necessary. That itself was costly, involving complex lab work. Then came sustained, directly observed treatment protocols. Community health workers, the accompagneurs, watched patients take every single dose of their long, difficult course of multiple medications.
Wow, that's intensive support.
Incredibly intensive. This level of supportive care, addressing not just the drugs, but side effects, nutrition, social support, was unheard of for TB patients in these settings then. Through this rigorous work, he gathered the data. Hard evidence that showed beyond reasonable doubt that with adequate resources, which he tirelessly fundraised for, initially from private donors, then increasingly from public bodies, and with unwavering commitment and this comprehensive patient-centered approach, the seemingly impossible was in fact achievable.
And that evidence made a difference.
Absolutely pivotal. It was published, presented widely. It forced organizations like the World Health Organization to reevaluate. It proved that the poor do deserve the same high-quality health options as the rich, and that doing so is not only ethical, but also practically effective in stopping the wider spread of deadly disease. It fundamentally shifted the paradigm of what was considered possible and ethical in global health. It laid the groundwork for more equitable treatment programs worldwide.
It's an incredible story of perseverance against the odds. And it makes you think, doesn't it? For clinicians today in constrained systems, Farmer's work really prompts us to examine where we might be accepting substandard care due to perceived limitations, and how we might champion solutions that uphold universal quality.
Precisely. It challenges us to question the status quo.
Beyond his monumental efforts against TB, Dr. Farmer also extended this radical philosophy to the HIV/AIDS epidemic, another formidable global health challenge at the time, especially around rolling out complex treatments. What was his stance on treating AIDS patients in developing countries? How did that align with his broader vision?
His position on HIV/AIDS was, well, equally resolute, unyielding, and again, quite dramatically counter to much of the established thinking back then. During the late 90s, early 2000s, complex antiretroviral therapies, ARTETs, were revolutionizing HIV care in wealthier nations. But many global health experts, policymakers too, genuinely believed these treatments were simply too difficult, too costly to deliver effectively in impoverished settings.
What were the arguments?
The arguments were that the health infrastructure wasn't robust enough, adherence would be an insurmountable problem, money should be spent on prevention, not treatment. It led to this tragic acceptance, really, that these life-saving drugs should be mainly for wealthier nations.
A two-tier system, effectively.
Yeah, exactly. Dr. Farmer was an unwavering advocate, almost a lone voice initially, for providing AIDS patients in places like Haiti and Peru with the latest drugs, regardless of where they lived. He saw this struggle as a direct continuation of his core belief. All human beings deserve access to the most effective medical care available, period. He fiercely pushed back against any notion of second-class medicine for the poor. He viewed it as a profound systemic injustice that just couldn't be tolerated. Denying treatment wasn't just morally bankrupt, he argued. It was also a public health catastrophe waiting to happen.
Because people would continue to suffer and transmit the virus.
Precisely. And his work, through Partners in Health, demonstrated convincingly that with sufficient political will, adequate funding, and critically, a commitment to building robust, community-based delivery systems, even highly complex treatments like RT could be successfully administered and monitored in these challenging environments.
How did they manage the complexity?
Through innovation, securing drugs at vastly reduced prices, navigating complex supply chains, ensuring cold chain integrity for certain medications, and again, crucially, using the accompagnator model for directly observed therapy and adherence support. They also recognize the need for comprehensive support, food, transport, social services. Because, adhering to a complex lifelong RT regimen is impossible if you're starving or homeless.
Right, it's the whole picture again.
It is. He proved complexity wasn't an excuse for inequity. It just demanded more comprehensive, creative, and compassionate solutions. For those of us in modern health systems, his insistence on treating the whole patient, not just the disease, and his relentless pursuit of access, it should challenge us to look hard at where we might be erecting barriers, however inadvertently, to optimal patient care.
It's one thing to have this powerful philosophy, this unshakable conviction. It's entirely another to translate it into Tangible, on-the-ground change, especially in places like rural Haiti. Dr. Farmer didn't just theorize, he acted often with this almost audacious determination and a remarkable knack for getting people on board. Can you walk us through some of the specific, almost improbable medical interventions he initiated, particularly in Haiti, the ones that really demonstrated this trademark combination of world-class expertise, unlimited compassion, and the unstinting dedication of friends and colleagues?
Indeed. His work really began in Haiti, didn't it? The poorest country in the Western Hemisphere, a place he dedicated huge amounts of time to, even before finishing medical school. Kidder paints this vivid picture of his early days in Cange, living among the people, learning Creole, immersing himself. He started by tackling the most immediate, devastating conditions, often with what might seem basic, yet profoundly impactful interventions, treating parasitic infections, tackling child malnutrition, ensuring clean water, providing vaccinations, foundational steps.
But he didn't stop there.
No, he quickly pushed far beyond that, driven by this conviction that the poor deserved the best, not just the minimum. For instance, Kidder recounts how he famously brought dying children from Haiti to Boston for treatment and cures. He leveraged his connections at Harvard Medical School, taught Boston hospitals like Brigham and Women's. This wasn't just basic treatment, it was bringing the highest standard of advanced curative care like pediatric cardiac surgery to children who would otherwise have died from entirely treatable conditions.
That must have been incredibly complex logistically.
Extraordinary. International travel, visas, specialized medical teams, accommodation for each child. But it underscored his commitment to individual lives. It showed that every life, no matter how distant or poor, held infinite value. It wasn't a sustainable public health model, perhaps, but it was a powerful symbolic act that galvanized support and proved what was medically possible.
And then there was the open heart surgery in Haiti itself.
Yes, perhaps even more remarkably, he facilitated establishing open heart surgery in the poorest part of Haiti. Now just think about that. Open heart surgery, highly specialized, technologically demanding, incredibly resource-intensive in a country with virtually no existing reliable medical infrastructure, limited electricity, rampant poverty.
It sounds almost impossible.
It does. But it wasn't just symbolic. It was a practical testament to his conviction that advanced medical care shouldn't be exclusive to the developed world. He brought in leading cardiac surgeons, including the renowned Dr. Bernard Lown, a Nobel laureate and mentor, who shared his radical vision. They had to transport equipment, train local staff from scratch, build sterile environments in challenging conditions. It demonstrated his profound belief that with unwavering dedication, incredible perseverance, and the right partnerships drawing in experts and resources globally, even highly complex procedures could be made available to those in desperate need. These weren't just isolated acts of heroic compassion. They were systematic, deliberate efforts to build enduring healthcare infrastructure and local expertise, where others saw only insurmountable obstacles. Reasons to scale back, not expand care. It's a powerful lesson in turning audacious vision into concrete, sustainable action.
And how did this intensely personal commitment, these almost singular interventions, evolve into something more sustained, something systemic that could deliver comprehensive care on a much larger scale, serving entire communities? How did he bridge that gap?
That's precisely where Partners in Health, or PIH, comes in. The organization he co-founded with Ophelia Dahl, Jim Young Kim, Todd McCormick. It became the living embodiment, the operational arm of his, well, messianic philosophy of medicine, as Kidder puts it. It wasn't just about building isolated clinics. It was designed as a systemic effort to perpetuate and expand his comprehensive, rights-based approach to global health, marrying high-quality medical treatment with a passionate commitment to social justice. Their philosophy, often summarized as whatever it takes, really reflected farmers' refusal to compromise on care.
So how did PIH work in practice?
Through PIH, they built robust clinics and eventually hospitals, like Zan La Sante in rural Haiti. Crucially, they didn't just import foreign doctors. They systematically trained local healthcare workers, the accompagnators, again empowering communities, ensuring cultural relevance and sustainability. These community health workers were key. They walked miles to deliver medicines, provide directly observed therapy, offer nutritional support, build deep trust. This wasn't just medical delivery, it was holistic patient care.
Addressing the social factors, too.
Absolutely. They established innovative, community-based care models, providing far more than just pills, comprehensive services, recognizing that intricate web of factors influencing health. This included providing housing support, ensuring access to nutritious food, often through direct food programs, offering broader social support, like help with school fees or income-generating projects.
Because medicine alone isn't enough.
Exactly. Farmer understood that medicine alone, no matter how advanced, cannot solve health problems rooted in poverty, structural violence, social determinants. Treating TB with drugs is futile if the patient is too malnourished to absorb them or too ill to walk to the clinic. This integrative model, born from his profound on-the-ground experience and deep understanding of the communities, became a globally recognized blueprint for health equity. It unequivocally proved that a holistic approach, addressing social determinants alongside rigorous clinical care, isn't just beneficial, it's essential for effective, sustainable medical outcomes. It shifted the paradigm from charity to true partnership and systemic rights-based change. Its influence is still seen in global health initiatives today. For senior medical professionals, the PIH model offers profound lessons in building resilient health systems and community engagement.
That brings us to a really critical point you mentioned earlier. Dr. Farmer operated with this clear-eyed understanding of the interaction of politics, wealth, social systems, and medicine. For our audience, especially those maybe focused primarily on immediate clinical needs, why is this broader socio-political understanding so absolutely critical? Even if your day-to-day focus is patient care, it can feel sometimes like a distraction.
Well, this understanding is, quite frankly, vital, foundational. Dr. Farmer recognized with profound clarity that a patient's health outcome is rarely, if ever, solely determined by their clinical diagnosis or the availability of a specific drug. It is, almost without exception, deeply intertwined with their living conditions: safe housing, clean water, nutritious food, their education, social support, and crucially, the prevailing political and economic structures shaping their entire existence. He fundamentally challenged the implicit assumption that if someone is poor, they somehow deserve or are fated to receive inferior health options compared to the rich. He saw this as a profound ethical failing, a critical blind spot in conventional medical practice.
So for clinicians, what does that mean practically?
It means moving beyond a purely biomedical model, which, while essential, is inherently incomplete. It prompts us to ask not just what's the diagnosis and what's the treatment, but to delve deeper. What societal factors are contributing to this illness? What systemic barriers prevent this patient receiving optimal care or adhering to treatment? For example, a patient with diabetes might struggle with adherence because healthy food is unaffordable or they can't afford transport to appointments. Farmer understood that the structural violence of poverty and inequality actively makes people sick and prevents them getting well. He often used that term, structural violence, to describe how social structures themselves inflict harm.
Right. It's not just individual failings.
Not at all. His work showed that by ignoring these interactions, treating the disease but not the poverty fueling it, medical interventions are often temporary fixes, providing fleeting relief, not lasting health. At worst, a narrow clinical focus can inadvertently perpetuate the very inequalities that undermine health for entire populations. He relentlessly advocated for a paradigm shift, away from a cold cost versus benefits calculation in global health, towards one singularly focused on meeting the requirements of every individual. He argued that true medical impact requires actively engaging with, challenging, and ultimately transforming the social and political landscapes that shape health. This demands clinicians become more than just practitioners. It demands they become advocates. Understanding their role extends into social and political spheres if they're truly committed to equitable, effective care.
It really broadens the scope of what it means to be a medical professional.
It does. It's about seeing the patient within their world, not just their body. Recognizing that postcode can often determine health more than genetic code.
That's a truly compelling point. It suggests a much broader, maybe more demanding role for us than many are traditionally trained for, advocating for systemic change as part of the job. As we draw towards the end of our deep dive, it's abundantly clear Dr. Paul Farmer's life left an indelible mark. For our audience, particularly those mid to senior professionals looking to make a deeper impact, perhaps influence policy, what do you see as his most enduring legacy? And how might his story continue to inspire medical professionals today?
Well, his most enduring legacy is arguably his unwavering, utterly undeniable demonstration that radical health equity isn't just some aspirational ideal, but an achievable reality, even in the most challenging environments imaginable. He didn't just advocate for it, he proved it. Through decades of hard, on-the-ground work, rigorous data, he showed that high-quality, comprehensive care can, and indeed must, be delivered to everyone, regardless of socioeconomic standing, location, or anything else. He shattered the myth that there's an acceptable trade-off between cost-effectiveness and the fundamental right to health. He asserted unequivocally, no such compromise should ever be made.
A powerful message for leaders in healthcare.
Absolutely. For medical professionals at any stage, but especially those positioned to influence policy and practice, hospital level, regional, national room, he's an incredibly powerful reminder of the individual's capacity to drive systemic change. His story, as chronicled in Mountains Beyond Mountains, is a profound call to action. It reminds us of the importance of treating everyone as equally important, moving beyond simplistic calculations to embrace the imperative of addressing every individual patient's needs. It illuminates the immense power individuals can make to global health. One person, armed with conviction, expertise, and dedicated allies, can indeed move mountains of indifference, bureaucracy, cynicism. Reviewers rightly call the book inspirational, profound, and powerful, a masterpiece. It compels deep introspection, urging us to question our own assumptions about healthcare delivery, resource allocation in our own settings, our ethical obligations to everyone, particularly the most vulnerable. His life demonstrates with undeniable force that few committed individuals with high ideals can change the world. By consistently keeping paramount concern for the patient right in front of them, and by tirelessly serving as the best possible advocate for their comprehensive care. It's a blueprint for moral courage in medicine, challenging us all to look beyond immediate clinical duties to the broader social responsibilities of our profession.
Our deep dive into Dr. Paul Farmer's life, through Mountains Beyond Mountains, has been truly enlightening and, yes, profoundly moving. We've explored his uncompromising vision for health equity, his groundbreaking work against diseases like MDR-TB and AIDS in the toughest settings, and his deep understanding of health within its social and political context. His story really does compel us to reflect on our own roles in challenging the status quo and advocating for universal, high-quality care no matter where we practice. If you found this discussion valuable, please consider taking just a moment to rate and share the deep dive with your colleagues. Your support really helps us continue bringing you these important conversations. Thank you so much for guiding us through this extraordinary narrative today.
It's been my genuine pleasure.
And to you, our listener, here's a final thought to perhaps ponder. If Dr. Paul Farmer, working tirelessly in some of the world's most desperate conditions, demonstrated repeatedly that the impossible in global health was indeed achievable, what impossible challenges might we in our own clinical and policy spheres be inadvertently accepting as fixed? And how might we begin to dismantle them one patient, one policy, one system at a time?